This podcast is brought to you by the School of Advanced Study, University of London.
It is my pleasure as chairman of the New Zealand Education Foundation to welcome you this evening. The foundation was set up in 1990 to celebrate the 150th anniversary of the founding document of New Zealand, the Treaty Waitangi, and it has as its objectives to support academic exchanges between the two countries. And it has been done in a variety of ways over the years. And then in 2010 we made what I think is quite an important decision. We said, look, what we really want to do is to create legacy. We want to set up an arrangement whereby influential, informed individuals from New Zealand, from the academic community, but not just from the academic community, can come to Britain, present a series of lectures on topics which are of interest in the debate, the current debate going on in this country. We have had 4 years of that, and I think it's fair to say that all of the visiting professors to date have left behind a very significant legacy of interactions between governments, between academic groups, and between others. I have no doubt whatsoever, knowing the expertise that Professor Gauld has, that you will hear the first of his lectures, and that he will certainly leave behind a very important and appropriate legacy. So can I thank you for being with us and hand over to the professionals, Professor Nicholas Mays from the School of Tropical Medicine, who will chair the event. Thank you.
Thanks. Well, welcome to the London School of Hygiene and Tropical Medicine. For those of you who are new to this site, this is our second building. So it's my job really just to sketch out the agenda for this evening and introduce Robin Gauld. Robin's going to talk for about 40 to 45 minutes, and then Judith Smith from the Nuffield Trust, who's the Director of Policy at Nuffield, which is one of our leading health policy think tanks, is going to respond and set the scene for what we hope is a vigorous discussion. And then we'll have questions and answers perhaps for another 15 to 20 minutes. The idea is that we wrap up by about 7:30. So Robin is one of the most prominent commentators on health policy and health system reform in New Zealand. He's written a number of books and edited a number of collections charting the sometimes very dramatic changes in health system policy and perspective in New Zealand. And he's inaugurating this evening a series of lectures which are an attempt to compare and contrast and bring lessons and learning from New Zealand and introduce them into our debates here. The sheets on your chairs tell you something about the rest of the series, which is primarily focused on issues of the workforce, both the interchange between the two countries and also what we can learn about workforce policy in New Zealand. But tonight we thought we'd kick off the series with a slightly different perspective, relating really to the way in which the health system is evolving in New Zealand. The reason also generally for thinking about New Zealand is that in my opinion it's probably the most similar healthcare system in the world to the systems of the United Kingdom. We must always remember that. It's probably closer in its organisation to the way the healthcare system in Scotland is organised. So in a way, perhaps Robin would find it easier to draw his analogies and make his comparisons if he was giving this talk in Edinburgh or Glasgow. But at the moment, he's stuck with the impoverished, intellectually challenged English. Because there are obviously, like all health system comparisons, important differences. But Robin's going to try and draw some lessons and some learning and also give an interesting analysis of how the evolution of organised primary care in the New Zealand system has, if you like, diffused out into the wider health system with this notion of integrating care across primary and secondary sectors and community health services using the notion of alliance contracting and the building of alliances. And Robin himself will refer to his own personal experience as someone who's leading one of these alliances as well. Robin's a political scientist by background. It'll probably become apparent as soon as he opens his mouth that that's the case. So his interest is really in history, the culture, the institutional arrangements of healthcare, how they can be evolved in order to, in this case, deliver better healthcare. I'm just going to hand over to Robin. He's extremely welcome, I hope, and I'm sure we're going to have a very, very engaging lecture. Do I need to hand over this mic now? Right. I'm going to put this on you, a bit like getting some kind of award. I mean to... Oh, you can do it yourself then.
I'm going to say a word until it's on. Well, kia ora koutou. It's a real honour and a privilege to be here at the London School of Hygiene and Tropical Medicine, and delight to be here on behalf of the NZ UK Link Foundation, and to see two honorary Kiwis, of course, because both Judith and Nick, as many of you would know, have both spent periods of time living in New Zealand and probably know as much as anyone in the UK about the New Zealand healthcare system as a visitor like me. I just want to say a few thank yous. Thank you very much, Sir Graham, for your introduction and to the support of the NZ UK Link Foundation. Thanks especially to Lisa Fletcher, who's the chief organiser behind the scenes, and she's absolutely fantastic if you need anything done. Thanks to the Nuffield Trust for co-sponsoring the event tonight. We really need a Nuffield in New Zealand, so we have nothing of the sort. So if you have any ideas, come and talk to me. Thanks especially to the London School of Hygiene for hosting the lecture, and thanks again, Nick, for getting involved and facilitating that process. To the School of Advanced Studies, which is my academic base here in London. And I think that's about it. Now, before I move on, I just want to sort of say a little bit about how I'm going to be speaking tonight. So I'm wearing one hat as an academic at the University of Otago, and as Nick says, I've spent much of my career analysing New Zealand's healthcare system. But I'm also speaking with this hat on tonight as well, and that is as of the independent chair of Alliance South, which is one of these new alliances that Nick touched on. So I'm going to talk a bit more about Alliance South tonight as well. Now, for those who don't know New Zealand, I probably should say, who's been to New Zealand? Who knows where Dunedin is? Show of hands, good. So you will know that this is the furthest city in the world from London. Very, very long way away. You'll also know that it sits at the 45th latitude south of the equator, which is roughly the equivalent of the south of France, although those who've been there will know that it's more like somewhere between here and Scotland. It's a very long way away and a gorgeous place to live. So I just wanted to begin by raising some concerns. Now, I've been here for about 3.5 weeks, and the NHS is unsustainable, as I think raised daily in the print media. The answers to this seem to be, well, integration and innovation. But that raises the question, of course, as to what governance model is going to best support and facilitate integration and innovation. I think another concern that we need to bear in mind is that as potential patients or patients of the healthcare system, we all want what is the best system in terms of the organisation of care and the various clinicians involved in the process of care. And we all want the same thing for the clinicians, the various health professionals who work in the healthcare system as well. We want them to be organised in a system. And just some take-home messages. I think first up, a very useful message to bear in mind is that New Zealand has experimented very, very widely, as Nick alluded to, with healthcare reform over the years. We have had a lot of experimentation with top-down reform. So this is a reform which is required by legislation or by some sort of policy edict. We have had a flirtation with the market in the early 1990s, the creation of a competitive internal market model. We then moved on to have a national purchasing, or here you would call it commissioning model, which from what I can tell in my few weeks here is very similar to what the role of NHS England is. So this is sitting at arm's length from government, freed from political interference to spend the lion's share of the healthcare budget. This is the theory behind the commissioning or the national purchasing model. We have then had, for the last almost 15 years, I think, devolved democratic governance. So we're the only country in the world that has this democratic governance model of largely elected members making the local, essentially commissioning and planning decisions. Now, we also have had a considerable amount of experience in New Zealand with bottom-up approaches to policy development as well, especially so over the last 20 years or so. Now, these are an example of where clinical leadership can really make a difference. And this is what I'm going to speak in more detail about tonight. This clinical leadership and the bottom-up developments in New Zealand, which I think provide useful lessons for England and other parts of the world. Our present sentiment in New Zealand, we are really settling now, I think after a lot of machinations and experience around the idea of partnerships and networks, and that the various different players in the healthcare system should partner and leverage off one another's skills and investments and experiences. We've also, I think, in New Zealand come to the conclusion that there are very real limits to competition, and that instead collaboration is a better way forward. Now, we at the moment are pursuing collaboration through a whole of system approach, and I'll talk a little bit more about this whole of system idea as well. And this might best be described in the New Zealand context as a mix of top-down, because this is being imposed on the sector by government policy, but it's also drawing on a lot of locally and regionally and even nationally led developments through bottom-up approaches. So the governance model that supports current developments in New Zealand we might call experimental. And I'll talk about that in just a moment. And as I say, these developments provide potential lessons for the NHS in England. So this idea of experimental governance, which I'm going to talk a little bit more about as we go on and will help to underpin the discussions. It was, this quote here was taken from a paper published this year in Social Science and Medicine, and that was a requote from a 2008 paper on new governance models. And so what it says is that instead of top-down, hierarchical, rule-based systems where failures to adhere are sanctioned, or unregulated, market-based approaches, this new governance idea posits more participatory and collaborative models of regulation, in which you get multiple stakeholders, and they might include, depending upon the context of course, government, civil society, business and non-profit organisations, all collaborating together to achieve a common purpose. Now, in order to encourage flexibility and this idea of innovation, new governance approaches favour more process-oriented political strategies such as disclosure requirements, benchmarking, standard setting, audited self-regulation, and the threat, of course, of the imposition of regulatory regimes to be applied, or default regulatory regimes to be applied where there is a lack, and this is a very important point in the New Zealand context, of good faith effort at achieving desired goals. And in terms of what experimental governance in New Zealand aims for, it's really encapsulated in these 5 points that were concluded from a review of primary care workforce innovations in North America over the 10 years of the 2000s. It's a really good paper. I think it's a great paper in medical care earlier this year. And so what they concluded was that the innovation concepts, and as I said, this is where experimental governance is being aimed at in New Zealand, team care, focus on a population, additional resource support going into primary care, creating workforce connections between the different players in primary care and bringing in secondary care as well, and then role change, so substituting some of the work, for instance, that a GP or a primary care physician in the US context might undertake with, say, a nurse practitioner or a nurse or an allied professional. Now, you might be wondering about this picture. This is a article, and it's a dreadful example. I challenge you all to go home and choose your latest favourite article and try and perfect this art. It's actually really difficult. So this was taken in Brisbane, actually, just before a conference on primary care in Brisbane. First thing in the morning I took this. Out the hotel window, it's the Brisbane Bridge and River in theory, and the article. But getting the two in focus is nigh on impossible. So I challenge you to perfect the article, the art of the article. So just what I'm going to talk about in the next few minutes, just very briefly touch on New Zealand's healthcare system, then talk about the history of primary care organisation in New Zealand, both the bottom-up and top-down developments, then these current alliancing arrangements, and then draw some reflections on the performance of alliances. So our healthcare system, as Nick said, is very comparable in many ways, the closest to the NHS in England and, as Nick suggests, Scotland. We have tax funding. About 83% of total funding comes from the government, which I think is about exactly the same at the moment as the NHS. We spend a higher percentage of GDP than the NHS or the OECD. We have a single payer system, but we have a sort of a mixture of delivery arrangements. Public hospitals dominate the hospital sector and they are free of charge, but private GPs dominate the primary care sector and you pay to see a GP, which is a major divergence from the NHS. I presently pay around about £20 to see a GP for a consultation. There are various subsidies that mean that different patient groups will pay less, but everyone will pay, and the way in which GPs are funded in New Zealand is based on the idea that there will be a co-payment as well. We have gatekeeping, of course, strong GP gatekeeping. Dual practice is not uncommon in the hospital sector in New Zealand, so these are hospital specialists, about 40% of them, who also have a private practice. Now, they're paid on salary for their public hospital work, but their private work is fee for service and it's completely separate from the public sector. It's a rather murky area, but the private hospitals are separate and the private facilities are separate from the public sector. We are the only country, as I said, with this history of democratic governance, and we've had a lot of restructuring in recent years. Now, this is an entire lecture or even a course in its own right. So I'm not going to dig into it in any detail, but I just wanted to illustrate that if the Health and Social Care Act, and I was looking at the Nuffield Trust's schema the other day on how it all fits together, and I still feel a bit confused about it all, I'm sorry to say. And I think that would be the case for anyone who came to New Zealand. They would still feel quite confused within a few weeks as to how all of this fits together. We're a small country, but there's a complex set of arrangements. So just coming down to the local level, we have currently 20 district health boards. Now, these are local commissioning organisations, you would say. These are the elected and appointed bodies funded by government to undertake the planning and purchasing work locally. Then we have, in parallel, 32 primary health organisations, and these are coordinators of activity in the primary care sector, including of GP work, although we also have a series of independent practitioner associations, which I'm going to talk about as well shortly, and they do a lot of the behind-the-scenes work for GPs. These are GP networks. And down at the very, very bottom, we now have, since mid-2013, an alliance between the PHOs, or PHO, in each district health board region and the district health board. So it's a very, very complex landscape, and I couldn't possibly reduce the confusion in the short time we have tonight. And believe me, even for those of us who live in New Zealand, it remains quite confusing. So a very, very quick historical recap. So starting from the bottom up, now this was, you might say, an unintended outcome of the competitive market system that we had in place in New Zealand in the early 1990s. Now this was a system where the government created a series of purchasing agencies that would buy healthcare services under tender from competing providers. So these would be public and private providers competing for contracts with the purchaser. Now it was very quickly recognised that there would be huge transactions costs in having every one of the few thousand, 2,000 or 3,000 GPs negotiating an individual contract. In some cases it might have been a small practice, but we were talking at this point in time mostly sole GPs and sometimes small group practices contracting with a purchaser. So it was recognised by both government and by the GP leaders themselves at the time that creating a mechanism to negotiate contracts on behalf of GPs would be useful. And so this was the birth of the IPA, was in that period, the Independent Practitioner Association. So it was a GP-led initiative and GP-driven initiative, and has continued to be an important initiative. Now through the 1990s was really I suppose the heyday in terms of the growth and influence of the IPAs. We had about 80% plus of GPs by the end of the decade being members of an IPA. The IPAs were different in shape and size. There were about 80 of them by then. The largest had about 500 GP members, and the smallest had perhaps only a dozen or so GP members. IPAs had moved well and truly beyond just the simple notion of contracting. They had started to move into budget holding, and done so relatively successfully by the end of the 1990s. And so they were holding budgets, for instance, for pharmaceuticals, for prescribing, for referred services such as laboratory tests, on the understanding that they could reinvest any profits into clinical services, and any risk would be held by the purchaser, any risk of overriding the budget. Because of the budget holding, they had moved into comparative effectiveness research. Now remember, this is the 1990s, not the 2000s or 2010s, so this was a very, very early example of clinician-driven comparative effectiveness research. And so they were looking at prescribing patterns, for instance, at high-cost drugs, at the high prescribers. They were looking at which tests GPs should be ordering, which are the most effective and cost-effective tests, and then disseminating information out to their GP networks around the findings. So they were sending out information around best tests and best practice and so forth. They, of course, were building very strong primary care networks that also involved nurses and other practitioners in some cases. And by the end of the 1990s, had created a national organisation, the IPA Council, that worked at a national level on behalf of the IPAs. They had embraced IT, and by that point, New Zealand had the highest utilisation of computers in day-to-day work by GPs in the world, as far as I understand. Correct me if I'm wrong on this, but I believe about 90% plus of GPs by that point were using a computer on a day-to-day basis. And because of that, they were able to engage in population health improvement. They were able to scrutinise their databases and look at patients who hadn't been immunised, for instance, and call them in and work on immunisation rates, on patients who were at risk of various chronic diseases and so forth, and call them in. So in many ways, it was quite world-beating. And Nick, when he was in New Zealand at the time, wrote a very good paper in the British Medical Journal with the late Lawrence Malcolm, and called this a working model of clinical governance. So on chronologically now to the top down. The next major development in primary care in New Zealand was following the election of a new government in 1999. Now this was a government that had a different view of healthcare and the healthcare system from its predecessor government. And it came into power with a pre-election promise that it would reinstate publicly elected leaders into local regions and create a series of regions. So they went about a major restructure of the sort of hospital and regional governance arrangements from the national purchasing model, which I had mentioned earlier. They then, in the early 2000s, launched the primary healthcare strategy and the PHO idea, which I'll touch on in more detail as we go forward now. And so this primary healthcare strategy, and to be fair, the government had its heart in the right place. It spoke to the Alma Ata principles of the World Health Organization and underpinned the primary healthcare strategy with the WHO's 1977 agreement. And so this was a government that was concerned about social justice, about reducing inequality, about the inequalities between Māori people in New Zealand, for instance, and others. And they were concerned with population-based approaches to healthcare improvement. And so all of this was embedded in this strategy. However, unfortunately, the government really came up against the IPAs because these were a privately driven initiative by private GPs in private practice. So ideologically, there was a sort of a fight going on at the time. And so the government, I think, felt that they could simply subsume the IPAs within the new PHO model. This, of course, raised the ire of the GPs. They were a powerful and fairly upset bunch, and you might say justifiably so. They felt as though the gains that they had made through the 1990s were being ridden roughshod over. And so they said that they would fight the government on this, and spent much of the 2000s, in many ways, certainly the early 2000s through to the mid, doing so. It really became, I think, one of the great lost opportunities of healthcare policy in New Zealand. The IPAs remained, as I say, an organisational force and remain so today. The PHOs, I think, are in descent as we speak. The PHO policy, I believe, and I've written about this on more than one occasion, was never really properly thought through. Nick and I had a paper in the BMJ in 2006, I think it was, and I wrote a follow-up paper, a bit more detail about that period in 2008. And I still believe that the PHO was an add-on. We should have probably had either the district health boards doing all of the local commissioning or the PHOs doing all the local commissioning, not two sets of organisations. However, on the upside, the PHO policy and the government's investment in primary care did have some positives. there was a lot of new funding available for primary health care. And we're talking about an addition of 6 to 7% of the total health spend per annum for about 6 years being invested directly into primary health care. So it was very positive in that regard. We got enrolment with a general practitioner happening. We had always had a GP, but never formally enrolled patients with a GP practice in New Zealand. So in order for the GPs to become eligible for new government money, they needed to have a patient enrolled database. That meant that GPs could reduce their fees by about 50% by the time that 6-year period of funding investment had concluded. Fees again have gone up, by the way, and they're possibly close now to what they were, although not in real terms, before they came down by 50%. There was also a lot of new money going into new services. So chronic care management money was available through PHOs for a PHO that could show that they had a program for caring for chronic care patients in the community. There was money for improving access to services. So this was geographical barriers, for instance, or other barriers that patients might have to accessing care. And then there was additional money starting to try and bring a sort of a public health focus and align that with primary care for health promotion. So this was $2 New Zealand per head. I don't believe that that has changed over the years, about £1 per patient enrolled through a GP practice for health promotion. So the larger practices, of course, had greater scope to work on health promotion than smaller ones. And of course we had development of an infrastructure in primary care happening, or some might say another infrastructure happening. The primary care strategy in the PHOs also meant that in an evaluation that I was involved in, we published the paper in 2012, we looked at 12 countries at the extent to which, extent to which those countries were able to deliver on the 2008 goals of the World Health Organization, which was a revisitation of the Alma Ata Declaration of 1977 of primary health care. And so we found that New Zealand just pipped the post of the NHS actually, in terms of being able to deliver on these 4 WHO goals. And so a strong focus in New Zealand on the social justice through primary care, service delivery reforms reorganising around primary care, integrating public health, as I suggested before, into primary care, and all of this with caveats, of course, but certainly moving in this direction. And then policy dialogue happening across the sector and beyond the primary care sector. Institutions, however, do matter, and as Nick mentioned, I originally was a political science and public policy student, and anyone here who studies policy will know that institutions matter. And they matter a great deal in New Zealand, as I'm sure they do here as well. And so institutions matter in New Zealand because we have come to the point now in time where we have these district health boards, and then we have the 30 at the moment PHOs, or primary health organisations. There were over 70, close to 80 of these primary health organisations at one stage, but there have been a series of mergers over the last 5 years, bringing the number down now to about 30. The DHBs, the local commissioning organisations, the elected organisations, of course, fund the PHOs. They are both parallel systems and they work with a common population. The IPAs, of course, have continued to provide much of the management support to PHOs behind the scenes. Some IPAs have transformed into PHOs. So this is where I said it gets to be confusing, the New Zealand landscape. The 4 largest IPAs now basically are very large PHOs, and they have, or are as we speak, working on a partnership arrangement across the 4, which will cater to around about 2/3 of New Zealanders. Health system planning, of course, requires a joint planning mechanism. And so that brings us to the current developments of alliances and what we call ALTs and SLATs. And so the ALTs are alliance leadership teams and the SLATs are service level alliance teams. So I'm going to speak in more detail about these now. So the roots of the current arrangements are in the current government. This is a national-led coalition government who were re-elected just a month ago, actually, in our general election. And so this government came to power in 2008, armed with a document called Better, Sooner, More Convenient Health, a discussion paper by the Honourable Tony Ryle, who became the Minister of Health. Now, this document got at all of the things that high-income countries are concerned at the moment. Chronic disease, ageing populations, a workforce which has maintained a certain way of working for a period of time, hospitals and general practices and so forth. And so it was suggesting that there needed to be a new set of arrangements that sat somewhere in between the hospital and the GP to provide this better, sooner, more convenient care. So more round-the-clock accessibility, more advanced diagnostics around the clock and so on and so forth to try and reduce the pressure on the hospitals and get more of the hospital-based work happening in something that sits somewhere between the GP and the hospital, as I was suggesting. So in 2010, the government commissioned 9 of these BSMC, as we call them in New Zealand, business cases. These were selected from about 70 that were submitted from across New Zealand's healthcare system. So some included, for instance, secondary care as well as primary care. There was a diverse range submitted. Now the 9 that were selected were in a range of regions and each had quite a different focus, but there was a commonality, and that was the presence of this alliance governance structure. So what is an alliance? Where does it come from? It comes from the contracting industry. And so when you are building a skyscraper, for instance, or a bridge, or some other very large structure, you will generally have an alliance arrangement between the large companies, the largest companies, as well as perhaps the subcontractors in that project. And the reason for the alliance is because everyone wants the project to be completed on time and in budget. And so the contractors, the big companies, agree to work with one another, to share resources where necessary, to ensure that that goal of completion on time and within budget is delivered on. So this is where New Zealand's alliance idea comes from. The health alliances are now in place in every district health board region in New Zealand since mid-2013. And this is for a range of reasons, you might say. Number one, I think the government has simply decided that the alliance is the way to go. Number two, you could say that the people who are behind the chief architects of the alliance policy have actually largely come from or have had a lot of experience with the primary care sector in New Zealand. The chief architect, I believe, the chief architect spent well and truly more, perhaps closer to 2 decades as the chief executive of one of the IPAs, so has a lot of experience in that sector and moved to the Ministry of Health about 2.5 years ago now, I think. And so we could have faith, I hope, that we're moving in the right direction based on experience with this alliance policy. So we now have a contract between, or a contractual requirement between each primary health organisation. In some regions there are more than one PHO, in others there is only one, and the DHB to create this alliance. I like to call it a mechanism to bring the different players together in the region. And so these are the aims. So to build a partnership, to improve health services, to develop a whole of system approach to service planning. So bringing the different parts together with services provided in the best place as clinically agreed. Now this clinically agreed point is very, very important. Down the very bottom point, it's also about building clinical leadership across the sector. So building on the clinical leadership that we've seen through primary care and through the IPAs especially, and trying to extend that clinical leadership out to include hospital specialists, allied healthcare providers, nursing, ambulance services, and so forth. And so to build on that and to draw on clinical leaders, essentially, to make decisions for how care should be designed and delivered in a region. To keep the patient at the centre is really, really critical to an alliance. What does the patient want? How would the patient like to see care configured if they are moving through the system? And so this is where an alliance is very much focused on integration and reduction of duplication in the process of care. And then finally, alliances are focused on allocating resources where they will best deliver on the goals and service designs of the Alliance. So you'll be starting to wonder how much power an Alliance has. I'll come on to that in a moment, but I'll just talk first of all about the membership. And so it's a mix of both health professionals and of course managers, because managers hold the resources. It's very, very important that the members, especially the clinical leaders, are respected within their clinical areas, that they are able to bring their clinical colleagues with them, that they have the capacity to lead and to influence and to understand the perspectives of their profession. And members might include any of the following. So you would expect to see the chief executives of the respective Alliance partners, some healthcare professionals, perhaps ambulance, aged residential care services involved, Māori, Pacific leaders, patient and community representatives, and then ideally an independent chair as well. What binds an Alliance together is what's known as the Alliance Charter. Now this is a very brief document, it's only about 3 pages at very most, but it's a very, very important document for what it says, and it's critical that an Alliance member reads, understands, fully comprehends what the Charter means, and then signs the document collectively with the other members of the Alliance. And this Charter essentially outlines the rules of engagement, and it commits the membership to a number of things, as listed here. So members must be honest, they must act with integrity, and they must seek to build trust in one another. This is pretty much the number one point. They must work collaboratively, seek to make decisions by consensus, and seek to resolve any disagreements cooperatively. They must be patient-centred, take this whole-of-system approach, and then of course they are involved in resource allocation, so they have to be involved in the whole process of prioritisation and allocating the finite amount of resourcing to services that an Alliance has agreed should be funded. So coming down to the power question, very, very important. How much power does an Alliance have? Well, potentially an Alliance is a game changer, and this, in my understanding and belief, is the intent of an Alliance. I am coming to the conclusion that this Alliance policy and idea is the most fundamental shift in the institutional arrangements in New Zealand since the Social Security Act was passed in 1938, and the institutional arrangements that sit under New Zealand's healthcare system were then developed in a compromise made between the government and the medical profession in the few years following 1938. I think this is the most fundamental shift potentially through the Alliance model that has happened since. The Alliances have a mandate essentially to determine local priorities. Very, very importantly, the local power sits around the Alliance table. So I listed who those people were before, and I'll go into that again in a bit more detail in a moment. And then professionals, very importantly, are there as well. Now, the District Health Board does have some reserve powers and can use these, but this is quite unlikely because the Chief Executive is a member of the Alliance. So possibly the reason why a DHB might use its reserve powers could be that an Alliance is dysfunctional, unable to make a decision, for instance, that needs to be made. So there is this reserve power. So on to Alliance South, which there's the red flag, which I should have said at the outset means that I'm wearing the Alliance South Independent Chair's hat. So this is our structure, and other alliances are likely to have similar structures. So what we have here is the leadership team, and I'm just going to get my piece of paper out of the pocket so I don't forget who these people are. I just thought it would be useful to go through who sits around the table, not by name. Now, we have been meeting now for 14 months, and we had what you might call a quite traditional alliance structure for the first 12 months. It was a transitional team. It was basically a team of people who came along to the first meeting. So the DHB sent essentially a number of its executive leadership teams, so the Chief Executive, the Chief Operating Officer, Chief of Planning, Chief Medical Officer, Chief Nurse, and so forth. And then we had the Primary Health Organisation Chief, a couple of GPs and a nurse. Now, most of the alliances in the country, the last time I looked, which was about 4 weeks ago, still look like that. Now, we have gone through a process in the last few months of reconfiguring our membership. It was mildly controversial, but we felt as though we needed to try and get the membership right. And so what we've gone for is what we consider to be a brains trust model. So we first of all, the DHB and the PHO, in consultation with myself as the independent chair, looked at the sorts of positions that needed to be there around an alliance table to be able to deliver on the idea of an alliance. And then we looked to populate those positions. Once we had the alliance, the transitional team agree to this is what the alliance should look like, we then sought to populate. And what we sought to do was seek out basically the best person in consultation with the DHB and the PHO who would take up each of those posts. And so what we have now is the chief executive of the PHO and the DHB, of course, the chief operating officer who's in charge of all of the hospitals, the chief of planning and funding from the district health board who holds essentially the purse strings and the planning strings. We have a public health physician, medical officer of health for the region. In fact, he's a recent medical migrant to New Zealand. He's been there about 2 years, but has a lot of experience with health systems, essentially, and sees things from a systemic perspective. So we wanted the public health, but having that additional systems perspective has been very useful. We have a intensive care surgeon who has huge respect amongst the surgical and medical staff across the region, but also wears the hat of quality improvement because this gentleman is also a quality improvement evangelist and understands all of the literature and approaches to quality improvement. We have a performance measurement and specialist who comes from the University of Otago Business School and is a specialist in lean methods as well as quality improvement, but his role is to be focusing on both the quality and the lean methods, the integration ideas that lean can contribute to, as well as performance measurement for our alliance. We have a nurse practitioner who has been chosen specifically because she's a nurse by training, but a nurse practitioner. You have nurse practitioners here? Yes. But she also has spent many, many years working in the aged residential care sector, so across nursing and aged residential care. So she brings this sort of multiple skill and multiple perspectives to the alliance. We have a representative of the ambulance services. We have a chief executive from a rural hospital. I should mention that the southern region in New Zealand is New Zealand's most vast by far. It's about a 6-hour drive. Some of it is absolute wilderness, wonderful country. But a lot of what happens in the southern region is rural. We have 2 main cities that have hospitals, but then a lot of rural. So we have the CEO of a rural hospital that works on contract to the District Health Board and works well and truly beyond scope because of where it is located and because they've been very forward thinking in terms of how a hospital like this should work in the modern world and in the future. We have a rural GP who works in the town of Wanaka, beautiful place. Anyone who's been to Wanaka? Wanaka is a very interesting area because it has a transient population. It's a small town of 3,000 people, but it has ski fields and summer sports. So a lot of accidents, a lot of injuries, and a very transient population. And so they have a medical practice in Wanaka, which again works well and truly beyond scope. And so he's there to represent the GP perspective, but also to help push things beyond scope in terms of thinking about general practice. We have a mayor of a rural town to bring the community in. What would the community want? What would the patient like to see? We have a Māori representative elected by the Ngāi Tahu tribe, which sits across the South Island, and then myself as the independent chair. So that just gives a bit of a flavour for what our alliance looks like. We're really quite excited about it. The meetings have been much more energised and much more focused on the work of an alliance than the more traditional structure that we had. We feel now that we will be able to really start to break down some of the boundaries that exist institutionally within the healthcare system. Now we also have a series of service level alliance teams. So we have 5 at the moment, and these will continue potentially to be added to as new areas of concern come onto the radar screen that the alliance is the obvious place to try and do something about. Now each of these slats, as they are called, is clinically led essentially. We tried hard to get the membership of the leadership team itself as clinically led as possible. It wasn't easy, but the SLATs themselves have possibly only one person who is non-clinical. So again, you would imagine a spectrum of healthcare professionals involved in a SLAT. And so the work of the pharmaceuticals one, at the moment they've been looking at both hospital-based as well as primary care-based prescribing patterns, variation prescribing, high-cost medicines and so forth. So looking at data, but they're also looking at questions such as what happens on discharge from hospital. How is the process of prescribing and handover to the GP managed so that the GP understands what's been prescribed and why and doesn't prescribe something else. The acute care demand SLAT has been largely focused on the emergency department and emergency demand management, and so a rapid response team has been created. It's not district-wide yet, it's just in pilot mode, but this is a rapid response team that includes access to hospital specialists by phone for backup and support. It involves nurses, and it's a team that the ambulance service can call out or a GP can call out to try and get a second opinion, and if need be, get social services involved and so forth, respite for a patient rather than sending them to the emergency department. We also have the Southern Pathways reporting to the Alliance. Now, these pathways are effectively clinical guidelines, although they're a bit more involved than clinical guidelines. They are developed locally. They're local adaptations of guidelines used largely in the Canterbury health system in New Zealand. And so they involve, ideally, GPs and specialists sitting down together to work out the process of care in a certain area and then writing that process into the guidelines. So the GP knows who they can phone up if they need an opinion, rather than sending a patient through for a referral to outpatients and having that patient maybe wait a month or 2 or 3 or 4 months for that. And the pathways in this regard are considered to be transformational. That has certainly been the case argued in Christchurch in the Canterbury health system, that these pathways have been very, very important to transforming how care works in Canterbury and is integrated. I won't go into this in any detail. This is just a bit more about what each of these slats has as its goals. So integration, helping clinical decision making be made on a best for system, best for patient basis, and providing leadership within the provider community. And then providing advice on how resources should be reallocated to support the decisions that the SLAT is making. So on to the funding question, because I'm sure you're thinking, how's all this funded? Gosh, there must be a lot of good new funding for this. Well, the short answer is there is no new funding. And actually the southern region that I'm from has one of the most constrained funding environments in New Zealand, and it's been ongoing. It probably feels much like the NHS, I understand, feels like from reading the newspapers. So there is no new funding, but what the government, well, the 9 pilots, I should add, they did have additional funding, but the rest of the alliances don't. And so what the government has done is come up with this idea of flexible funding. So I mentioned earlier the funding for chronic care, for access improvement, and for health promotion. And so the PHO is allowed to use that funding in a flexible way locally, because currently that funding is simply segmented out to each PHO to be used for those purposes on a national basis. So the idea is that if an alliance has made some decisions around chronic care management, for instance, it can take some of that funding and start to channel it into the new road that the alliance has chosen to take. And the DHB will add to that funding pool as well. And so you'll get a progressive growth of funding going into this flexible funding pool over time. Much of this has yet to be tested. Now, if you want to read more about this, I've written a couple of blog pieces since I've been here in England, one in The Conversation, one in the Guardian Health Professionals Network that have just come out this week, but I also had this paper published in the Medical Journal of Australia a couple of months ago that has just a little bit more detail in it. This is a self-tickle, world first. This is a photo of yourself in front of a new paper. It's much easier than an article taking the self-tickle, getting it all in focus. You can see I've been alone for too long in London. So what do we know about Alliance performance? It's very much still a work in progress. And some might say, now that the red flags have come off this, some might say that actually this is a policy that's just been embarked upon without enough knowledge about how well it's going to work. There were some evaluations commissioned, or these were evaluations that were funded based on a competitive grant round. So I put in for one of these. This was over 2 years ago now that we bid for this grant. We wrote the proposal, partnered up with an alliance, and then my colleague Jackie Cumming from Victoria University in Wellington also partnered up with another alliance. We were in contact with one another, formed, I guess you could say, a research alliance, and joined our projects up. We both were successful, and so we have written a joined up final report. That report is still with the Ministry of Health and should be released sometime in the next few weeks, I believe. What I can say is that here's what we aimed to do, essentially to evaluate these pilot alliances, to see whether these business cases led to integrated care, improved the patient experience. These were goals, of course, written into these business cases, and then reduced emergency department admissions and ambulatory sensitive hospitalisations for particular patient groups, such as older people and people with chronic conditions. We had a mixed method approach, so these were sort of partnership evaluations with assistance from the sites. So we collected routine data, we interviewed, conducted surveys where possible of clinical staff, management and patients, and undertook document analysis. And here's what we found. The red stuff are what you might say, the downsides or the negatives. We found that the goals and the targets were far too ambitious. And so we're talking here about reducing, for instance, ED admissions within 3 years by 30% through increased coordination of care in the community. So highly ambitious. So some might say they were always set up to not meet these targets, to fail essentially. That because of this, there were too many new initiatives being rolled out simultaneously. This put a lot of pressure onto frontline staff especially. And so all of this meant that they've had quite a rocky start. There have been leadership questions in both sites. There have been questions around the Alliance leadership teams themselves about the dominance of managers to the detriment of clinical involvement in the Alliance, and this leading to clinical disillusionment. However, and this is a very, very, very important point, the bottom one in green, these business cases have started to steer the ships in the direction of one ship, a very, very important new direction. And so this is perhaps the most important point that's come out of our evaluations. So just to wrap up now, some conclusions. I suppose what I've been trying to say here tonight is that our GPs in New Zealand have built a very strong primary care foundation. They've shown that clinical leadership can make a difference. There has been high levels of clinical leadership and engagement in at least the IPAs, if not the PHOs, over time. Alliancing now is offering an important new mechanism for building cross-sector clinical leadership and getting clinicians involved in the core decision-making, and clinicians leading core decision-making around how services should be configured. The idea, as I've suggested, is yet to be fully tested. It's really just begun. But very, very importantly, it's getting everyone in the room and it's giving them the potential to have conversations that were not possible previously. Now, the very first Alliance meeting that I went to as the independent chair, I was stunned that there had never been a mechanism that brought together, that there had never been a chance for the DHB and the PHO to sit down and talk together about, how should we do it around here. I was absolutely floored by this. And so it's getting everyone in the room and allowing these clinically led conversations and which are helping us to focus on what the system should look like from both a patient and a professional experience. In many cases, it's been quite profound. It's certainly in my Alliance. Certainly in New Zealand, we're moving rapidly into an age of experimental governance. We're starting to move beyond the sort of hierarchy and the silos and starting to try and look at harmonising the interests of the different actors in the healthcare system. It's, I think, going to be a long road. It's a work in progress. In the meantime, much of the old infrastructure remains in place, including the funding and reporting lines and so forth. We are seeing the emergence of what some might say is a complex sort of web of both horizontal and vertical arrangements. Some are complaining that it's very, very messy, but it's possibly, you might say, all part of the transitional process from one sort of set of arrangements institutional arrangements to a different set of institutional arrangements focused on this whole of system approach. Now, what should galvanise the alliances is the introduction of the Integrated Performance and Incentive Framework, the IPIF, or IPIF. I still haven't worked out whether it's the IPIF or the IPIF, but we'll call it the IPIF. Now, this is a framework that's been under development now for quite some time, and it is likely to be introduced sometime into the new year, from what I understand. And it is basically aimed at whole of system measurement. So in order to perform well on the IPIF, you need to have a well-functioning alliance. Indeed, one of the indicators is of a well-functioning alliance. Quite yet how this will be measured, no one is certain. But there are various other sort of whole of system measures that are included in this IPIF. And now the IPIF will have extra capacity to influence the functioning of an alliance and the movement toward alliancing, because at least in the draft documents, and I don't know whether the final arrangement will include this, but the government has been looking at a series of different sort of steps of development, and basically, I suppose it's a bit like your foundation trust arrangements, giving more freedom to alliances that are shown to be well functioning. Well, thank you very, very much. Just a plug again about next week's lecture on health workforce, another topical issue that's been in the media in recent days. What was it, £610,000 to train them, and then $3,000 a year are going to Australia and New Zealand to the sun, but not the sun in Dunedin, as we know. Well, thank you very, very much. And over to you, Julie.
Well, good evening. I'm Judith Smith, as said earlier, from the Nuffield Trust, the charitable health research foundation based here in London. And I spent from 2007 to 2009 living and working in New Zealand, in Wellington, in the capital city. What I've been asked to do tonight is to respond to what Robin's been saying, and really you've been, I think, masterful in kind of encapsulating so much of the history and context, Robin, in such a short space of time. So what I've got just a few reflections. I'm going to say something about what I think is actually distinctive about the New Zealand health system, and something about what, from my perspective, I think England can learn and keep learning from New Zealand, and also some thoughts about where we might need to be a bit cautious in making some of the comparisons. So I think there are some people sometimes feel there can be almost like could be infections in terms of policy ideas going from one country to another. I think we've all experienced that in different ways. So I think it's how we intelligently, I can't remember who it was, but there was an academic once who talked about it's almost like you take a plant and carefully graft it. You know, you want to make sure you're not taking the weeds from another country and things. So, but I can't remember which academic that was, but. So what do the, yes, first of all, sorry, yes, what do the two systems have in common? Clearly they're both largely tax funded. The strong demarcation of primary, like general practice, and secondary hospital care. I haven't talked so much about this yet tonight, but I think both countries would say we've got hospitals which are in probably significant need of reform, particularly struggling what to do with our smaller and middle-sized hospitals to keep them safe, and giving appropriate services, because we need to have them, particularly in New Zealand because of the dispersed population. But thinking about how they relate to a work with primary care are a really critical issue, and I think again the Alliance has probably got a lot to offer there. We're all having to find ways of caring for people with multiple long-term conditions. I think in our different ways we're trying to use financial incentives to nudge change in the system. And I think perhaps tonight we're thinking about how we nudge change with professionals, but I guess there's a wider question about how we might be wanting to nudge change in how people live their lifestyles, because again, both countries facing significant public health issues around obesity and so forth. And also, I think, Robin's made it clear, we've got a history of governments almost treating the health system like a train set. You put together and play, and like those wooden train sets where you just sort of mess around with it, but at the end of the day, the train still goes round, doesn't it, hopefully. I think, yes, your market experience of the 90s being perhaps the most vivid example in New Zealand of that. What for me is distinctive about New Zealand's health system, I think that we have to say, clearly the country in terms of population size is of a different scale. It is more similar to Scotland. And I think, we have to be honest, that offers a degree of simplicity in terms of perhaps what you can do and the speed with which you can do things, compared with if you're dealing with a much larger population and more complicated often, just you've got regional sort of arrangements to deal with on top of the institutional ones. Another important point, and I always found, and I know Nick, you've often said this, when one lives and works in New Zealand, people don't so much think of it as a sort of a health system, because I think with us having the NHS, that's a very clear institution of itself. But my experience in New Zealand was it's much more thought of as a set of publicly and indeed to some extent privately funded services. There are many fewer statutory organisations involved in health services governance and management, and it wouldn't be quite such a difficult task as my colleagues in my team at the Nuffield Trust have had in trying to draw the bizarre web of arrangements we have now since our recent health reforms. I think in New Zealand there's a much greater tolerance of diversity of funding and provision, not wanting or expecting that everything should be just the same everywhere, not necessarily wanting things neat and tidy, which I think is to some extent a problem in the NHS. For me, working in New Zealand, there's a very strong history of public health medicine and of that function more generally, the orientation and fantastic data and analysis that underpins a lot of what happens. It's probably something you don't appreciate when you live at work there, but that's an important point, and particularly tonight being where we are to say that. And the long-standing and strong primary care networks with their roots in the IPAs. What would we give? Certainly, what would I give? For us to have general practice networks that's been around for 20 years, that have been able to have that stability and to build influence and capacity in the system. And there's been no major reorganisation in New Zealand now for around a decade, which I think is a very significant point I'm going to come back to, similar to the Scots, of course, as well, who've had that stability. There's been the major retreat from market-based approaches that were dominant in New Zealand in the 90s, and actually I don't think there's the same degree of financial austerity that our public services are facing at the moment, albeit I know times have been relatively tough of late. So just 3 slides on what I think we can learn from New Zealand. You can't get away from the fact that organisation and policy stability is important. The time and effort, well, it's worse than that, the distraction caused by the structural reorganisations that we've been having, I think, on average about every 4 years, and that's at the longest gap probably over the past 2 decades or more. Also, New Zealand has an interesting and I think quite powerful legislative framework for its health and disability system that really emphasises public health and equalities and dealing with inequalities in a different way from what we have. And I think it provides more than a framework. It actually provides quite a strong focus to what people do. And again, I think one that perhaps one notices almost as an outsider than necessarily when you're come from within the country. I think the value of having professionally owned and led primary care networks is incredible, and they can't be reorganised. Robin mentioned that the Labour government spent a lot of time trying to get rid of the IPAs in the early 2000s, and I guess if only they could have embraced them in one sense and worked with from an earlier stage, we might have been where we are even sooner. But I think that's a really important point for us, and something to think about at the moment in England as we're experimenting much more with federations, super partnerships, different arrangements for general practice that have grown out of general practice. I just hope and pray the government doesn't try to take them over and appropriate them for themselves, because that for me would be the beginning of the end of them. There's the value as well of letting local managers and clinicians innovate and test things out. I don't know whether it's number 8 wire you talk about in New Zealand, isn't it? People get on and do and make things happen because they kind of have to in a dispersed, with a dispersed population, the country that's a long way from most places. But I think that's fantastic, that innovative spirit, which we just don't have to the same extent, I don't think. Again, something that hasn't been mentioned, but for me is important in New Zealand, there's a Health and Disability Commissioner who ultimately upholds the rights of individuals in the health system. And I think it gives a much clearer sense of both how to complain, but how to understand what your rights are in the health system. And that, again, is something I think that's an important feature that runs through New Zealand's healthcare. And then taking an incremental approach to a national performance framework. I think it's quite healthy. It's taking a while to think it through and work out how to have that, rather than necessarily just go straight for a big set of targets or, in that very top-down sort of way. So I think that negotiating it through is something for me that's quite powerful. But where might we need to be just a bit cautious when we listen to what Robin has to say and look, again, more generally at what's happening in New Zealand? Alliancing, I have a question. Is it what we've often called joint commissioning in this country? Or is it moving further than that? I don't know yet. The jury for me is still out. In one sense, it's got some similarities to joint planning arrangements and so on we've had in the past, lots of people around the table and so on. But for me, there's a real question, will it stand the test of when financial risk is really shared? When perhaps services have to be decommissioned. Will the secondary care, the hospital clinicians be quite so keen when actually going to take money out of intensive care to move it somewhere else in times when money's quite tough? So yes, how strong is that secondary care clinical leadership within and their commitment to alliancing? I kind of have sensed that sometimes the general practice and primary care side are enthusiastic, but I'm wondering, how the secondary care colleagues will be when the going gets tough. And I'd ask the same question of our integrated care initiatives here. And I think for us, though, in England, there's a real question about how alliancing could actually work in a context of competition and markets. What would monitor our economic regulator think about all those people being around the table having the responsibility for making those significant planning and funding decisions? That might be something we want to discuss. But both countries have got to find effective ways of better sharing risk with providers if we're going to make the significant changes we need to do. And alliance contracting and alliancing is being looked at and experimented with in some places here in England. But the serious service reconfiguration I think we need in both countries in different places. It needs strong political, managerial and clinical leadership. So we come back to that question about, will the alliance be the vehicle that's fit for purpose for that? Or how will it have to evolve over time? How will it, take on, in a sense, contractual financial risk and hold partners to account? And what happens if they don't do what they're supposed to do? What are going, in a sense, when they're tested in that very real way? And then, at the end of the day, in New Zealand, like here, the government, via the Ministry of Health, or the Minister of Health, is accountable for the performance of the publicly funded health services. How will they hold the alliances to account and measure and challenge their progress? And will they tolerate it if one's lagging a long way behind the others? Will they start trying to sort of benchmark them and kind of what effect might that have? Because politicians don't tend to have very long time frames. I think in New Zealand it's every 3 years, isn't it, between your elections, making 5 look quite luxurious here. And we all know the way that imposes certain pressures and challenges on public services. And finally, I just have a challenge that I think in a publicly funded health service in countries like New Zealand or the UK, I think some hierarchy is inevitable in terms of the way that accountability works. But the question for me is, if only within those respective hierarchies, we could be focusing so much more on outcomes. And I think you've got the potential to do that with your alliancing approach. And we talk about it, but don't actually do that here yet. So my conclusion is, I think there's a lot to learn from the alliancing perspective. For me, the jury is still out, but there's definitely something attractive and interesting to keep a very close eye on. So thank you, and thank you, Robin, in particular, for stimulating the thinking.
Thanks. This Q&A session is going to be slightly stilted because I understand the roving mic isn't working. Is that right? So we need because we're streaming this, we do need a sort of record of the question, and then we can have I'll then hand the mic to Robin and he can answer. So if anyone would like to kick off, we'll maybe gather a few questions together and I'll try and summarise them and then Robin can answer them. It's a bit like translation, isn't it? It's like being at the United Nations. So, and say who you are, that would be really helpful as well.
Do I need the roving mic?
I'm going to well, I'll tell them who you are, maybe, if I can remember. Paul.
Both Judith and yourself, Robin, mentioned the idea of a change in epidemiology from sort of more acute health problems to chronic problems, where I think the health system has to adapt from treatment to more management. So the emphasis is simply on the care bit. What hasn't come out of this talk is whether there's a relationship with social care, and how does the budget for social care integrate into this, if at all, because we now have this Health and Social Care Act, which gives opportunities to develop different care arrangements and care provision, and subsequently how does training adapt to these changes, the training programs?
Thanks. We'll take another question or comment from anybody. So that was, how does the new alliancing arrangement incorporate what in New Zealand is called disability support, so long-term care and domiciliary support, particularly for older people with disability in their own homes, and what are the training implications of moving into a system which is more likely, like the debate in England, to blend and to break down the barriers between healthcare and social care or disability support. Another point at the back there.
Sorry, I just wanted to comment concerning the private sector and on the primary level in New Zealand, and how the private sector and out-of-hospital care link with secondary child care.
Okay, so that was just a point of clarification really about the, I mean essentially if you're talking about general practice in New Zealand, it has the same ownership status as general practice in the UK. So the practices are private businesses and they are funded in various ways by out-of-pocket payments from patients and also some public subsidy.
Half of a GP's income is from public sources in New Zealand, roughly speaking.
And yeah, the point being that it's a much, whereas in England or in the UK, most GPs, it's well over 95% of their income will be from the NHS. In New Zealand, it's about half from public sources because there's a much bigger user fee. Does that help, just to clarify? At the front here. Yeah.
Thank you. So I'm Linda Hutchinson. I'm a paediatrician who 2 years ago set up my own business to introduce alliance contracting to health and social care in this country. So firstly, can I just say it's fantastic that what's happening in New Zealand and that people are taking the time to come here, because it's, as we're trying to introduce it to people saying, using the construction and infrastructure model and oil industry, people say, but have you used it in health services? And we always go, yes, in New Zealand, and so on. So firstly, can say that. I mean, I'm really struck by what I've heard, and thank you for that, because what I'm experiencing here is people want to start small. So I'm working with people who want to do it in mental health rehabilitation, or they want to do it over here with youth unemployment, because we're working with other public sectors as well. So we're starting small and then expanding and building, whereas what I'm hearing is you went big. And your reflections on that would be really useful in informing our journey. Thank you.
Okay, so that was the point to ask Robin to reflect on the issue of scale. And in fact, the Southern, whatever you call it, alliance is one of the smaller ones in population terms, isn't it, than some of the others. Okay, so we've got basically two issues really to discuss: the boundary between healthcare and disability support or social care, and how that will be managed, and what are the workforce implications, and also this issue about scale. Do you start small and build up, or do you go for it? Well, it's got my time wrong. There you go.
It's very, very complicated. Well, thanks for the questions. Right, so the disability support budget, as Nick said, it's about 20% of public expenditure through the health budget is for disability support services, and it's sort of cut in various different ways. Largely it's for people who have permanent disabilities, but there is a bit of money that also goes into sort of aged care support services as well. Then there is money that comes from other pockets for aged residential care services as well, and that is aged residential care is means tested. So there are some sort of overlaps and grey areas. It's quite complicated, but roughly speaking, that's how it sort of fits together. Each district health board, for instance, has an aged care needs assessment service, and so an older person who might have been referred by, say, a GP for assessment will go through. They use the Inter-RI tool, and they'll go through an assessment and make some decisions around how much support the person might need in their own home, which the district health board will pay for, or whether they might need to be moved into supported aged residential care of some sort, in which case they go through a means test process. Does that answer the question?
I think in part it was more about whether when somebody's needs are identified, where's the boundary between saying that's almost a health issue and that's a social care issue? Because I think they're becoming blurred.
Yep, so where's the boundary between the health and the social issue? It's a good question. I mean, I probably don't know enough about that particular field to be able to give a totally accurate answer, but you might get a geriatrician and a GP and an aged residential care or a home-based support service all involved in a conversation about what should happen with a particular client. So they might start out being a patient, then become a client of the support service. So they work in a fairly team-like way, although I think there are always cracks in that system as well, various people being available and so forth.
I mean, what you don't have is the social care responsibility held in an entirely separate organisation.
Yeah.
So the district health board is responsible for both what we call health and social care. It's a bit more like the arrangement in Northern Ireland, but perhaps somewhat more integrated.
Mm-hmm. Now, the second question, which was scale of alliances. Well, alliances are they're a forced marriage. The government has said this is going to happen between the DHB and respective PHOs, so they've said it starts big as such. Now, we've always tried in the southern region to try and keep it contained, because what I learned through those evaluations was that going too big, too full-blown was trouble early on, and they've been grappling with it ever since. So we're trying for something that's in between. So we've tried to stick with just those 5 sort of service level alliance areas at the moment, and 3 of them are still in a very, very embryonic state. They are still just being composed with members, and the sort of terms of reference and the focus is still yet to be worked out. And that's taken us...
What's the nominal population for your...
so 300,000 people, but across a vast district. So the largest alliance areas would be about 500,000. Although there was an alliance, one of the pilots was in the Greater Auckland area. It was over 1 million people, but it was mainly focused on after hours, sort of emergency after hours care. I understand that it has now fractured into 3 DHB-based alliances. Does that answer the question?
Yeah, it does, and in fact, it's probably quite similar where you're taking a service area, like your outpatients or something, and then you're adding others. So it's probably not in dissimilar places in how it's evolving, albeit the context of competition.
Now, and around our meeting table, the discussions are often quite messy, because the GPs will be coterminously talking about a referral for a certain kind of patient, and then they'll talk about mental health, and then they'll talk about a disability support service type question, and they'll talk about diagnostics access, and so trying to sort of contain those discussions and focus them is quite difficult. But it's really quite useful having the broad scope of basically what's integration in this region, which issues are about integration, and so which are the issues that we should be focusing on. That's how we try and contain the discussions. If they are discussions that involve both secondary and primary, then it matters to us. If it's a primary only issue, then it probably doesn't matter to us. So much of the day-to-day business of the hospital and the GP matters less to us, unless of course it means providing more educational support and scope of practice support and so forth for a GP. And that's where it's yet to be tested. And this comes to the point that someone made around shifting of the budget from the hospital out into primary care. That's the longer term aim. And one of the markers, at least in the draft performance incentive framework, is how much of the budget basically has been shifted. What's the balance between secondary and primary? And so there will be a sort of an optimal point that the policymakers are aiming for.
Robin, I'm going to suggest you chair your own questions so that we don't have this rather stilted business with me taking the mic and giving it back to you. So if you want to, it's not because I don't care about it. Over to you.
All right, no, thanks.
And keep the mic for a few minutes.
Yes.
My name's Tim Richardson. I was a... Oh. All right. I'll hold it now for a while, if I may. Tim Richardson. I was a GP. I'm retired now, but I was very much involved in fund holding, then provision through personal medical services, then practice-based commissioning, and then we had an opportunity to move back into the provider network field by incorporating the commissioning budget on top of the GP contract under what was called an ICO pilot, Integrated Care Organisation pilot, and I believe now that was sort of fractured by bringing in clinical commissioning groups. So we've bounced backwards and forwards from are we commissioners, are we providers? GPs are always providers of primary care, but what are we in respect of the rest? And I'm slightly confused with what you've told us as to whether your organisation is a provider organisation or a commissioning organisation. So that's number one. Two, I think we talk a lot about, and there's scepticism about competition, but the biggest competition in healthcare is within the NHS. It is totally between the silos, holding on to as much of the resource. And whilst you can get, like the Darcy London and Next Stage reviews, lots of very good clinicians of all walks of life to come up with a strategic re-evaluation and reconfiguration of services, which has been reinforced since by KEO. When it comes to the local level, the local consultants will say, no, you're not taking that service away from our hospital. So my second sort of question or point would be is, how are you going to resolve that as the need becomes increasingly clear that far too much chronic care is done in an acute care setting because that's where the resource has been invested, and how are you going to get it out of the acute and into the community primary care sector?
All right, no, thanks. We'll just stick with those two questions, if I may. So the first question, which was around, see, I didn't write it down. We're a commissioner, that's right, yes.
Or are you a provider?
Yep.
Does the buck stop with you?
We are a decision maker. We are a mechanism for making decisions around how care should be configured in the region. And then the partners to the alliance go forward and implement those decisions. So they resource the decisions and then see that they are implemented. So some people said, well, the financial buck stops with the partners, essentially, because they hold their own budgets. Gradually, they will pool those budgets. So much of this is a work in progress, and certainly in the context of the non-pilot alliances, yet to be tested. But the aim is build trust, focus on what the patient wants, focus on what clinically makes sense, not on where you always worked and where the resources always sat, but what clinically makes sense to a GP and to a specialist who sit down and talk together about how should care, say for referrals through to rheumatology or whatever, work, and then resource the decision that is made. So that's what the Alliance's job is, essentially. So we are neither a commissioner nor a funder, but a mechanism for bringing key decision makers together to make those sorts of decisions. And now the second question is the very contentious one around the taking resources from one place, the redistribution, essentially. That has yet in our region to be tested. We are having those discussions, and they are discussions which will come to a conclusion at some point in certain areas, and they're likely to be contentious, but that's the way of the future, essentially. And if they're clinically led discussions, there are likely to be disagreements, but what the clinician says should go, essentially, in a clinically governed system. That's our theory.
But the two clinician voices of secondary and primary care will both be saying same thing when they don't have to make a decision like in a Darcy review, and different things when it becomes a service reconfiguration immediately on their own patch.
Many of ours would say that actually they've got far too much work. The hospital specialists have far too much work, and if only they could get rid of, say, 30% of the patients coming to outpatients and have them seen elsewhere by a supported GP, for instance, then they'd be able to free up a whole lot of time for people who really need to see them. So these are cancer specialists, for instance, saying this sort of thing. So many are saying, bring it on. Well, it wouldn't directly affect them because the patients never stop coming. So I don't think jobs are under threat. I think what's potentially going to be difficult in the future is what happens about bricks and mortar, when you've got payment going to run a hospital, as well as perhaps additional payment having to go into primary care to provide advanced scope of practice. So that's where it's going to become quite difficult. So perhaps I can come back in a couple of years and provide some more answers. Was there a question over here?
Yeah. So I'm Francis Livingston. I'm a Kiwi, currently working in the Department of Health.
Oh, I should give you the microphone.
It's okay.
This is for the streaming.
Right. So yeah, I'm currently working in the Department of Health, and one of the topics I'm working on is integration. And you can think of integration at several levels, I think. One is policy sort of joined up at national level, which seems to be the case in New Zealand. Is it joined up at a local level, and certainly with the alliances? That seems to be a kind of key development. But then there's also integration at the sort of patient level, so other professionals and the carers, etc., are working together so that the patient isn't having to repeat the same information, isn't seen by a number of people unnecessarily, has a sort of continuous care, etc. So I was just wondering to what extent New Zealand's kind of cracked that patient level integration.
I think the answer is it probably varies in different parts of the country, and not terribly well would be the answer. Some parts, such as Canterbury, have probably cracked it more. They've been very focused on the use of the pathways, which I talked about earlier, and that's really where the clinical level engagement across the sector takes place to try and reduce the duplication and work out who should be doing what where. So we're starting in on it, and it varies in different parts of the country. This pathways model is now basically being rolled out in every district health board region quite rapidly. There are, from what I understand, a couple of different systems being used, or different software providers working with the different regions. One is called the Map of Medicine, and then there is the pathways that we're using in the southern region and in Canterbury. So does that answer the question? So the integration at that level is happening to different degrees in different parts of the country. And that's what we, certainly in the alliance that I'm the independent chair of, we're trying really hard to focus on that, to try and break down all barriers and get clinicians to talk to one another so that they can sort out exactly how the system should work for common patients of certain services. So everything from outpatients through to diagnostics and so forth, referrals to outpatients, getting access to diagnostics.
I have a follow-up question, and you touched on it, is IT is often, here it is a major barrier, particularly between health and social care. So social care, for example, dealing with elderly people who need care, can't see necessarily what NHS treatment, etc., medication is. So it sounds like there's a couple of areas in New Zealand where that isn't such an issue in terms of the professionals being able to see patient records and history.
Yep, so the question was around interoperability, essentially, IT systems that support integration. I think you're right that in some parts of the country it's better than others. In the southern region, the whole of the South Island has an initiative underway, but we're dealing with legacy systems. And certainly several months ago, I saw a presentation that suggested that there were multiple different referral systems, multiple different patient administrative systems and management systems in existence across the 6 districts in the South Island, and there's an effort underway to try and better integrate those systems. It's quite a work in progress, and it's pivotal really to the work of an alliance to try and get this right and get it happening. It's a very slow work in progress as well. I think other parts of the country, such as I think the Midlands region, which I know a little less about. I should be more informed about the Midlands area, which is again an IPA, originally IPA-driven network that became a PHO and now is the Midlands Health Network. Now, I think that they have e-referrals now through to the major base hospital across the 370 GPs. Most GPs get electronic discharge summaries anyway. They're collecting data, it's just that the systems are legacy systems, so they don't necessarily have the level of interoperability that's required. Yeah, so there is some care. There are one or two companies as well. You're right, that have care planning software, and so again it varies. So that was the county's Manukau DHB you were suggesting. So they may use a company called HSA Global, who I think are active here now. They're very focused on care planning. Oh, you're the person from HSA. Okay. Was there a time? All right.
Yeah. We're standing between our audience and some drinks, I think, and Sir Graham wants to thank you again for the lecture. But Robin, thanks for sharing your own questions as well.
Thank you.
Thanks to technology. Sir Graham, do you want to leap back into action?
As Nicholas so correctly puts it, I have 3 thanks and an invitation. Firstly, the thanks are to you as the audience for being here. No lecture is successful without a good audience, and you clearly have been an engaged audience. The second is to thank Nicholas and Judith for their contributions, but my primary motivation is to thank Robin, A, for being here as our visiting professor and for giving such an engaging presentation.